Yes, good night.
Hello and welcome. I'm Councillor Danielle Lind and I'm Councillor for Blakebury Board and I chair Children and Young People's Overview and Scrutiny Board here on Derby City Council. I'm going to go through the room so you can all introduce yourself please from the right.
Okay, Councillor John Whitby, Councillor for Mackworth and the Vice Chair of this board.
Nikki Fenton, Church of England Rep. I'm doing this principal manager at Derby City Public Health and lead commissioner for Health and Sunday. Nicholas Smith, Assistant Director of Children's Commissioning at Derbyshire ICB.
Hi, I'm Pauline Morgan and I'm the Director of Learning, Inclusion and Skills Policy.
Hello, I'm Omar, I'm the Youth Man, and I'd also like to apologise on behalf of Gloria, the Deputy Youth Man, for comment.
Hello, I'm Madame Stiles, the Children and People's Participation Officer at Derby City Council, and I'm just here to support Omar and express scrutiny.
I'm Dominic Monahan, I'm the Democratic Services Officer.
I'm Dean, I'm a dentist and the local dental network chair for Derbyshire.
My name is Rose Lynch, I'm the Senior Commissioner Manager from NHS England, within the Pharmacy Optometry and Dental team.
Good evening, I'm Adam Morby, the Regional Chief Dentist from the Midlands, and just role 4 days a week and practitioner 1 day a week.
Hi, I'm Clive Newman, I'm the Director of GP Commissioning for Derbyshire ICB. From next April, we'll have more responsibility for dental services.
I'm Tracy Churchill, Head Teacher of St Joseph's in Derby, and Yvonne around the Councillor for Abbey Ward.
Councillor Kerr, of course, I'm the Councillor for Alveston Ward.
Thank you everybody and welcome to our evening meeting. So apologies, I've had 2 apologies so far from Councillor Gwilym and Councillor Miles Patterson. Is there any more?
We also have apologies for Sue Anderman and Andy Smith. Thank you.
Okay, thank you. No late items to be introduced by myself this evening. Declarations of interest.
I don't know what to do. I'm a Derby City Council foster care, so I suppose I would say.
And I'm a SEND parent myself. So item 4, minutes of the meeting held on the 20th of June. We all agree they're a correct and accurate record of that meeting. Yeah, nobody's split? No. Okay, so they're excellent. So moving on to item 5, which is NHS Dentist 3 early years dental care. I'll now hand over. Thank you.
Thank you, Chair. I'm just going to share slide. Thank you, lovely. Okay, good evening, everyone. My name is Rose Lynch. I'm the Senior Commissioner Manager for Pharmacy Optometry and Dental across the East Midlands. I would like to firstly thank the Derby City Health Overview Scrutiny Committee and the Children and Young Persons Board for inviting NHS England to the committee to provide an update on NHS dental services within Derby City. For this cohort of people in terms of access. So the paper, you should have all have a copy of the paper. It's quite a lengthy one. It has been developed by NHS England Commissioning Team, senior managers, our consultant in dental public health and also public health colleagues within Derby City Council who have joined us today in the meeting. We also have in attendance to my right is Adam Morby, who is our Chief Regional Dentist, and also to my left is Ron Khatib, who is our local dental network chair for Derbyshire. We also have representation from the Joined Up Care Derbyshire Integrated Care Board. That's to my right again. That's Clive Newman. And the purpose of input and attendance from so many relevant colleagues is because as we move into the direction of the collaboration in terms of the ICS integration agenda, that's why you have so many of us here today. And also we would like the meeting to be as constructive as possible, obviously answer as many questions for you as well. So the paper is about 30 pages long, so I'll take the paper as read. And whilst the report submitted does provide you the details in terms of NHS dental access within Derby City for children and young people, we'd like to try and draw out some of the salient points in tonight's meeting and within this presentation and to highlight what we think is pertinent to Derby City. So, first slide. So this slide provides an overview of the location of NHS dental services within Derby City. It's explained in more detail within the paper, and it also provides a map of where dental practices are located. So on the right-hand side, you'll see you've got some circles and they've got like some numbers in them. Those tell you the number of dental practices or clinics within that area. On the left-hand side, it provides you an overview in terms of the location of dental services and what was commissioned in the area. So we have 6 NHS general dental practices within Derby City. We have 1 8 to 8 extended out-of-hours provider who provides urgent dental care 365 days a year. We have 1 community dental service provider who provides specialised services across the whole of Derbyshire. And we do have some clinics within Derby City. Secondary care provider for Derby City access would be the University Hospital of Derby and Burton, so that's UHDB. And they provide orthodontic services, oral medicine, and oral and maxillofacial surgery. We also have intermediate minor oral surgery, also known as IMOX, and that's for more your complex extractions. So when you go to a dentist and say, I just need to refer to an IMOX provider, and that's probably perhaps the extraction is too complex for that individual clinician to remove. So you'll go into a specialist IMOX service. And there are 4 providers in Derby City providing that service. On the map on the right-hand side, you'll see that there's some purple areas. So the map provides an overview of the 20% most deprived communities across Derby City. It's denoted by the purple areas, which equates to 37.4% of people within the Derby City area who live in 20% most deprived areas. In terms of travel, all dental services are accessible by car within 10 minutes in rush hour. And also in terms of public transport, within 30 minutes of a typical weekday morning, and the access is quite good. I'm now going to hand you over to my colleague, Adam Morgan, who is our regional chief dentist, and will talk to you about the challenges within NHS dentistry.
Thank you, you're obviously all very acutely aware of all the different challenges, and some of them are highlighted there. So rather than reiterating what you can read and what's in the report, obviously, some of the most critical issues are for access to dentistry in the area, and children being able to gain access. We're hearing reports that patients can't get access, dentists are taking on patients. We're getting increasing numbers of families that are reliant upon food banks and the implications of the diet in relation to that for children. As Rose has mentioned, 2 of the contracts have been handed back. The activity has been redistributed in the area. Current contracts are running at about 82% activity levels, so that's obviously down on what they were pre-pandemic, and that is some of the reason for the difficulties in access. And then we've got things like the BBC report that everybody will have seen on the news quite recently that's reported the access issues nationally. For Derby, that was actually saying that there were 92% of practices were not accepting, and they actually their survey looked at 25 practices they contacted, which was slightly more and probably just slightly more outside the Derby City area. So what you will ask is, why is this happening? Excuse me, essentially, practices are contractors, independent contractors, and they're actually changing the balance of their practice to remain viable. So in terms of the NHS provision, they are sort of reducing that, taking on private patients, and that's keeping their viability going. As NHS contractors, we have, or as the NHS, we have no control over how they actually independently contract with us, other than being able to claw back activity that they don't achieve. The contract is only a change to the national level, so regionally we can only sort of inform national what the issues are and trying to guide that process. And there are some reforms that are actually coming in from October time, so hopefully they will start to make some improvements and inroads into some of the issues that we're finding. They are also trying to address the skill mix within practices, so therapists, the people within the practice can be utilised more to try and get a greater efficiency and throughput of patients. And we're working collaboratively with stakeholders as well to try and, like yourself, to try and influence different things with MPs in terms of water fluoridation as well. Because obviously there's no water fluoridation in Derby, which I'll come back to in a short while. We've got some data as well, the epidemiology studies, which I'll probably be able to refer to as well for 5-year-olds and 12-year-olds. So that actually this time will actually be looking at more chronic issues. It's the first time those types of questions have been asked. So obviously the previous study was before the pandemic, so we'll have a better understanding of the needs of those patients going forward when we've got the results of those epidemiology studies. I think next slide is back to Rose to try and look at some of the initiatives that we've tried to put in place to address some of the issues that we find at the moment.
Thank you, Adam. Yes, correct. So as commissioners, we have utilised several schemes across the whole of the Midlands. So Midlands have got the East and the West team. So with Derby City as part of the East team, they have had an impact and we have increased access, but unfortunately due to the limited number of practices, and the contract handbacks as well, the uptake has been quite limited. But where there are uptakes, then obviously that has been benefits in terms of the increased access for residents within Derby City. The initiatives we have commissioned is we have commissioned some weekday and weekend sessions. That's recognising the capacity within dental practices with regards to the downtime that a practice has to adhere to for the room to set up in case of any cross-infection control for the next patient that steps in. So recognising that, we've managed to commission some sessions where practices can open later in the weekday or the weekend, or if they've got the staffing, then obviously they can increase the number of clinics during the day just to try and obviously see more patients. We also have some dedicated urgent slots during surgery opening hours. There's 2 practices in Derby City who are offering 20 additional care appointment fees. And those 2 practices, as NHS England and as a senior commissioner, are great for these practices because it's on a goodwill gesture. Since the height of the pandemic, we've reached out to them, recognising the pressure on 111 and dental practices, and where they have, say for example, some practices may have about 3 or 4 spare urgent appointments a day, they were willing to give up 1 or 2 per day, specifically just for 111, so obviously they can help signpost some patients. So they're still on board, so we're really grateful for those practices. We also have we had some additional NHS dental sessions. So you may have heard the £50 million that came from the government. It wasn't a case of giving out X amount to this area and that area. It was a case of these are the sessions we were able to offer, and obviously we went out to expression of interest and standard dental practice to then come forward to express an interest in what we can actually offer. So as part of that, some of the 8 to 8 dental providers came forward and were able to offer more additional sessions on that side of things. We also managed to secure £150,000 on a current basis for 2 years, and that's in part of the oral health improvement funding. So that helps in terms of the oral health promotion and 2 commission packs, which I'm sure my colleague from looking over at public health will be able to expand more in detail and more information on that. So the challenges, as my colleague Adam relayed earlier, with regards to the workforce issues, it affects not only just dentists and the nurses, but the whole workforce as well. In terms of dentists, there are enough within the UK. However, not all dentists want to stay in the NHS, so that's the challenge that we have. There have been delays with overseas registrant exams with the General Dental Council, but I understand they're now moving along. So they should obviously be going through the system, so getting some more dentists on board. As part of that process, as NHS, we need to ensure that each clinician that comes on board to join the National Dental Performance List is assured to a standard to treat NHS patients. So which is why sometimes the length of time it takes for dentists to come through is because of that reason, it's that assurance for also patients before we're allowed to treat them. We've also got our local dental networks. They've been working with Health Education England. That's to address the workforce issues, and some of the strategy includes accessing schools and some fairs, just to try and encourage more local residents into the profession at all stages. I'm going to just hand you back over to Adam. It's got the Read to You show here, and he will discuss the next 2 slides from a clinical perspective.
So those are some of the initiatives we've got in place to actually try and deal with the issues here and now. Obviously, I think what we'd all recognise is prevention is better than cure. because obviously no one wants to see any relatives, be it children or anything, that are in pain and suffering. This is where water fluoridation comes in, because it will actually, the benefits of water fluoridation are well proven now to reduce extractions in dental caries. So, and it's shown that in areas where they haven't had water fluoridation in the past, there's 63% improvement in the likelihood of people having to experience dental pain and extractions. So it would make a dramatic effect if we could increase this in the supply of water to Derby City and the rest of Derbyshire as well. So this is where sort of, if we can sort of engage with yourselves as well to lobby MPs, because obviously since the changes with the Health and Social Care Act, we now can sort of lobby Secretary of State to make those changes basically. And their improvements are well and truly documented to be favourable. I know it has always caused in the past some concern with some people, but there's a very strong evidence base now behind it for its positive effects. And when you take into consideration the census change, obviously since 2011, there's been a 5.1% increase in population in Derby City, and 3.7% of those are children under 15. But water fluoridation doesn't just benefit just the children, it benefits everybody as well. So there's a great benefit to be had there. Next slide, please. So obviously other future opportunities is trying to work collaboratively together, and we have got work plans in place for all the different age groups that we've mentioned. We're working collaboratively with the local authority and colleagues to put prevention initiatives in place. We've got toothbrushing kits that are handed out through the food banks, health visitors with the Healthy Child programme. So we just need to integrate better with the wider healthcare as well, though, and have collaboratives to work, because there's very strong connection between gum disease and sort of asthma and diabetes as well, which will affect children as well. So we need to work with all these different partners, along with Health Watch, and get it right first time as well, who are now working not only in secondary care, but also with primary care practices to look at the efficiencies that can be made there. And then, as I say, hopefully with the changes that come in with the first marginal changes that come in with the contract in October, they'll start to make inroads to the difficulties that we're experiencing, and they are just the first steps to contract reform that are ongoing currently. So I think that concludes what I'd like to say, and so open the floor to any questions.
Basically, thank you very much, and thank you for the hard work that you are putting in to try and address some of the issues. What I would like to ask is, are you expecting the reforms to tackle the national contracts, and to review the national contracts?
Yes, the reforms will sort of, to a certain extent, help. Obviously, we need to sort of just get them in place first of all from the 1st of October. So there are some legislative changes that will take place before they can be brought in, but it is planned that they will happen around the 1st of October time. So hopefully those changes will sort of increase the throughput of patients within practice, because the one issue that has been happening up till now is with the pandemic and the delay in patients being able to access dentistry, patients are now coming in needing more or requiring more treatment. So that's actually taking longer periods of time within practice to see those patients. So if we can actually spread that need amongst more people that have got the skill to deal with their issues, then it will hopefully increase the throughput of patients.
Yeah. So are you hopeful that there will be bigger access, a lot more access in Derby City?
Fingers crossed there will be more access because of these initiatives, but they're not going to probably answer everything. They are just the first step on the process, because it's a bit of a balancing game at the same time, in terms of the fact that practitioners are choosing to work more privately, and that's one of the big issues that we've got to try and retain practitioners within the NHS, make the services that they're able to offer an attractive package for them to be able to offer and keep their practices viable.
I may add just to this point, as a practitioner working in general dentistry and NHS dentistry, the reform contract that they're suggesting for October is, if nothing else, a morale boost for dental practices and dentists. And it's the first time in over a decade that there's been some easing of the dental contract and the pressures surrounding it and the targets. So, we were saying earlier, there is enough dentists in the country. It's not viable for them all to work within the NHS. It's not financially viable. And a lot of new dentists graduate from dental school with an ambition to work within NHS dentistry, but unfortunately they are slowly pushed out. So it's a big morale boost, but it will make things a lot more efficient because we are needing to do more work. And part of the reform is that we get better targets for doing treatment on people who require several fillings, for example. Whereas in the past, it made no difference whether a person needed 1 filling or 5 fillings, we would still get the same amount of funding for that. So this is going to be a significant change. And as I've said, the fact that therapists are going to be contributing more to our workforce is also going to help. So very positive changes, and it is part of some ongoing negotiations in terms of further improvements with the contract. But yes, there is some more work to be done.
And when would you expect that initial access to improve here in Derby?
Well, I would have thought within a couple of months from October, as soon as the contract is released and people get to know how the system works effectively, I would like to think that there will be an improvement. Some things will have an effect sooner than others. Introducing the therapist into the skill mix, that isn't an overnight thing. That needs time. That needs patients also understand that there's a teamwork here, and sometimes there's a bit of reluctance from patients to accept treatment from a therapist. They say, well, I'd like to see my dentist to do my thing for me. So that's a little bit of a culture shift that will take time to happen, but it's got to start somewhere, and that's the point of where it is starting. But other things will be immediate. The fact that we are getting more funding or easier funding to do treatments on patients, that will be instant. So that should have an instant effect.
One of the other measures that's been brought in as well is more adherence to the NICE recall guidance. So what actually we're trying to move away from is the patient expectation that they'll be seen routinely every 6 months. So patients will have a risk assessment carried out to sort of understand how often or how frequently they need to be seen. Some people that have high disease prevalence with decay and things like that will need to be seen more frequently, whereas you get some other teenagers that will not have any sort of experience of dental decay. Hygiene will be very good, and they will need to be seen less frequently. So generally, when that's applied across all the different age bands, that will free up access within the actual the appointment books of dentists as well. So there's several different components all coming together at one point in time.
We are now working on that dental strategy in terms of patient communications as well, just to help patients understand that access and access into dentistry and the expectations of dental practices.
Yeah, I think it's extremely concerning that children and people are struggling so much to access these services. I mean, I've contacted my residents. I've asked for their feedback. Some of my residents are telling me that they're forfeiting their own dental health to be able to pay privately for their children and people, which is, again, that's concerning because, it's putting more pressure on the system somewhere else. So I do hope that will be taken on board and we can move forward with that. I'll open the floor to any other questions.
Not for you.
Okay.
With the reforms in funding, that include changing the band on, for example, extraction or root canal? Because I know if you have extraction or root canal, the class is band 2, I believe. An extraction is what 5-10 minute job compared to a root canal treatment, which is 3 different visits, which is a lot more time on this service, the outcome for the patient, that you probably get the same funding from the NHS. So is any reforming
that has all been addressed in part of the reforms. So for argument's sake, the patient will still experience a band 2 course of treatment, but the patient will not know anything any different. If the patient has less than 3 fillings, the dentist is remunerated in the same way, they'll just get 3 UDAs. If they do 3 or more fillings, they'll get more UDAs, units of dental activity. So it's the dentist that's actually, the patient's not paying anymore, they're still paying a band 2 charge, but the dentist is getting paid more for the time they spend with the patient. If they actually then go on to do a root canal on a molar tooth at the back of the mouth, that will attract even more UDAs, that will attract 7 UDAs. So the time element that the dentist is spending with the patient is now being reflected in the amount of activity return they're given, which goes towards their contract to produce their targets.
Yeah, but when does that kick in, sir?
That will be from October time.
And it's quite apt as well because pre-pandemic, the complexity of patients accessing intervention wasn't as high. Obviously, since practice closed during the pandemic and the backlog, patients that are now presenting are needing longer treatment. So obviously, as part of this dental contract reform, it helps recognise this.
Yeah, just 1 or 2 questions if that's okay. Paragraph 10.8 mentions children in care struggling to get appointments, and that sort of rings true with me as well. And I don't know if there's anything you can tell us to assure me that they are getting placements with dentists first of all, and they're being seen in a timely manner, because obviously they're most vulnerable in society, and they're going to move around more, so they're more likely to need different dentists, etc., etc. So.
Yeah. Fortunately, we have got some good networks basically within different areas. So when these issues are brought to our attention, we are managing to get sort of children placed with dentists to get access for those types of services. But yes, admittedly, there have been difficulties in the first place, and it has been then brought to our attention, and we are addressing that. One of the things we're actually looking at to work with before the pandemic, there's quite a little bit of work done with looked after children and trying to develop programs for them, basically. One of the paediatricians from the Birmingham Dental Hospital, who has done quite a bit of work on this, is actually a fellow who will be working with you for the next 12 months and picking this bit of work back up again. Her colleague had also worked on the same issue in sort of the Yorkshire and Humber area, and now the learning that they've had there, we're bringing back to the Midlands and trying to work with colleagues at local authority level to roll out that type of package across the whole of the Midlands, so that we don't end up with these types of issues and looked at children are dealt with in more time.
Presumably, like schools, children in care on top of the whatever admissions policy you've got. Okay.
Yeah, the class is vulnerable patient groups, and we do work with them, me and our other colleagues, local dental network shares to help with that messaging as well, because we should be prioritizing.
And if someone rings for an urgent appointment in the morning, are they going to get an appointment that day? Child in care.
Yeah, well, there's no formal procedure to sort of guarantee that process, but we always do prioritise children, and we certainly do prioritise children in care.
So how long does it take to get an urgent appointment?
So I would usually say if they are in pain, we would want to see them on that day, and I say I can't absolutely guarantee it, but most of the time we will absolutely do that, and most dental practices will certainly prioritise children patients if they're in pain. Sometimes it may not be the very first practice they get contact with, but they usually find someone on the day. And we do also have links with the safeguarding team, and they sort of can contact us directly. And if there are any concerns, then we've got a network of dental practices, and we know the dental practices, so we work together to support them. So there are lots of links to support children in care. And we are really working together to strengthen those links and formalise them.
And what's the biggest reason for struggling to get appointments? Is it staffing issue, or is it also related to the sort of the practices post COVID, longer periods between appointments, etc.? Was it a whole?
It's a combination of everything. Everything's happened together. So the pandemic, as Adam said earlier, even though we are running at full speed, in effect, we're back to how we were pre-pandemic in terms of how quickly we are doing the treatment and the length of the appointment. Every patient that comes in is requiring much more treatment than they used to.
Right. Well, I was going to say, I presume it's built up a whole.
And unfortunately, yeah. So that then takes time to manage all the treatment that those patients need. Workforce is a significant issue, not just because dentists are choosing to go out of the NHS, but dentists are burnt out. A lot of them have taken earlier retirement than they perhaps would have done. A lot of dental nurses have also left the profession, and because the working environment has been very, very challenging with the additional PPE. and a lot of the nurses had left, and they've decided they don't want to come back because they've developed different careers. And vaccination was an issue. And again, personally, I've lost a couple of nurses who chose not to get vaccinated because that was enforced. Then obviously that got cancelled. But again, they said, well, we've got our jobs now elsewhere and we're out of dentistry and we don't really want to come back. So staffing is a significant issue. And the national contract has obviously been a significant issue, and hopefully things are helping in that respect. So unfortunately, it's a perfect storm of a lot of things that have come together, but there is work being done locally and nationally to ease the pressure.
Just one quick final one.
The other thing I was adding to that, some of the practices that may be single-handed as well. Obviously, just a couple of weeks ago, we had to test twice weekly as well with the lateral flow tests. So in a practice where you've got a single-handed dentist with just one nurse working alongside him, if that nurse caught COVID for one reason or another, all of a sudden he has got that spare hands to actually provide dentistry and work with. They then have to sort of get a locum nurse, and the day rates for those can be anywhere around the figure of £300 a day. So it's extremely difficult financially for them to try and manage that when somebody may be off for 10 days. That's a £3,000 burden.
It's the follow-on.
Okay, I'll come in later. It's only a quick question.
You, Matthew.
I have two questions after reading the paper, both which relate to public health and commercial. First question is, do children, when they have a health check, also get their teeth checked?
Would you like me to answer the question with regards to how we provide helpful health messages to children and their families? So currently, every family will have a mandated visit from health visitor 5 times from a period from pre-conception to 2.5 years. And that's a face-to-face visit usually, and every contact that health visitor will talk through the importance of good oral health. And at particular visits, they will share how to correctly brush the child's teeth, how frequently the child should brush their teeth, and if the child is able, they've got activities to do with the child, so that the child competency can understand some of those key messages as well. And that's part of good practice guidance that health visitors follow, which is called the Health Child Programme. We do locally also implement some additional initiatives in addition to those 5 contacts. So at one of those contacts, when the child is pregnant 6 to 8 weeks, it's about informing the parents. The parents will get a toothbrushing pack, which includes toothbrush, toothpaste, and again, to be made aware of some of those key oral health messages. And we're also looking to do a more targeted oral health visit at the 1-year development review. And at that point, what we're hoping to do is to identify some of our vulnerable communities, some of our families that are at more risk with dental decay, and put some more specific interventions for those specific families. So it's part of what we call in health every contact counts. So every opportunity, we will raise those messages with children.
Second question is, could public health work with nurseries, children's centres, play groups to encourage brushing teeth and raising awareness about the cause of tooth decay?
Absolutely, that's a really good question. So historically, supervised toothbrushing, which is what you described as a really good evidence-based intervention, it's something that we have previously delivered within Dogs some years ago, and it's something that we would really like with the support of NHSCI as intervention and second role. It's something that collaboratively we're looking to explore, and what we intend to do, it's not going to necessarily be universal intervention, so open to all early year settings, but we'll be targeting those early year settings where we know, looking at our data, where we know that this is very high, and we'll be working with our providers in relation to that intervention. But that's, I know our dental colleagues have been advocates for that intervention, so that's something we want to do. But in the meantime, when we get that off the ground, we are looking to enroll some training, run some more output training for our children's centre practitioners, early years providers, other practitioners, so those that work within physical activity services so that they can integrate or have promotion messages within their own deliveries.
I just add to that, I think you bring some excellent points, and communication and education is the absolute key. The sad thing is that dental decay is completely preventable, and the key is to educate the parents, to educate the children, and that's sort of what we always aim to do in practice. There is also an initiative by the Chief Dental Officer for every child to have a dental checkup before their first birthday. And again, while there may not be a lot to see physically in terms of teeth, it's about getting that contact, getting the information across to the parents about diet and brushing, and to get the children experiencing the dental practice, so that when they're older and there is something to see, then they're less anxious about visiting the dentist, and that's also going to help.
Through the pandemic as well, it was recognised, obviously, the reduction in the number of children that was seen, and the Chief Dental Officer actually put a programme in place to help with the risk assessments and understand how to deliver care sort of to young children. So.
Councillor Bonster?
Yeah, just briefly, I mean, there's a lot of hope here that this new contract is going to kick in and probably, encourage some of the dentists who've perhaps moved away from NHS practice back into the forum. And, I sincerely hope that is the case, that is the result. But I think it's important that we continue to monitor this situation probably very early in the new year, to see whether there's whether there's been that impact on the services being provided. And my experience, in my own ward is that parents, they pick up the phone, they try to make the call, and they've got to go to work, they've got their busy lives, and these things just get kicked down the road, and you're obviously seeing the impact of that in terms of the work that's got to be done when these people do eventually find a dentist and get their children in front of them. So I think it's something that we've got to continue to collectively to monitor closely.
I think one of the added difficulties that I've been told of from families that I've spoke to is particularly with the deaf community that's really, really struggling even further to access support, to access anything at all, really. They've got dentists trying to ring them, they can't answer. So I don't know what more can be done there to be inclusive to the deaf community. They're obviously having difficulties.
We do have access to interpretation services. So if a patient is obviously on the moment and they require interpretation services, then just have access to sign language.
That's good to know, yeah. I feel that.
We also have a scheme which we're currently working on, with some funds for all the areas within these segments, and that's the target urgent care provision for patients. At the moment, we're currently doing some scoping as to what's within each area, and then we're going to commission something, and then we're taking learning and evaluation from that, and then working towards a gold standard. So just mind that not one size fit all, so obviously it will be a bespoke service for each area within these segments. So we are currently working on.
Another area of concern that residents are raising with me is the concern of overuse of antibiotics. So I was just wondering what impact overuse of antibiotics is that having on children and young people? What reliance is there on antibiotics for children and young people when they're awaiting extraction, for instance? Generally, do they have it once? Do they have it 3 times? How long is that wait? And, are they using antibiotics?
Dentists are generally actually very good at not prescribing lots of antibiotics. As part of our Care Quality Commission inspections, we have to show our audits showing what antibiotic prescriptions we've given and how many. And we are acutely aware of antimicrobial resistance and complications of that. So I would say generally as a profession, we do not give out antibiotics a lot. And unfortunately, a lot of dental disease is not fixed by antibiotics. Antibiotics may temporarily resolve it, but we know that it's not going to fix it. So, we often will attempt to do whatever treatment is required to resolve it. And yes, there is an issue sometimes if they're waiting, for example, for a general anesthetic. to have their teeth removed if they are quite young and they can't tolerate having the treatment and the surgery under local anaesthetic. Yes, there may be a wait, and in those cases, there may be no other option than to give antibiotics. But that isn't the norm, and that isn't something that happens very, very frequently. We can often also, or we would also usually temporize the teeth, put dressings, put medicine into the tooth to temporize it. So an antibiotic prescription isn't a huge issue, I don't think, within dentistry.
It obviously did increase through the pandemic, but it is reducing again. And it is World Antibiotic Awareness Week in November as well, which we are arranging through comms for patients. That's reflected recently, excuse me, the bank holiday we've just had, where so we put out communications to say antibiotics don't cure toothache. So there's lots of comms that's planned for both patients, dentists, and raising that awareness to antibiotic resistance.
What is the average weight for an extraction at hospital children in grade to?
It varies from hospital to hospital. I couldn't actually answer that tonight, I'm afraid. That data, I don't know that.
Yeah, just thinking about like we do every day about rapid increases in energy costs, and thinking with small businesses, there's no cap on energy costs, etc. Is this going to discourage some people from doing NHS work because they're not going to get paid? Well, are they going to cover the costs? The hike is going to be, God knows what, 10 times pay now. Are they going to be sort of encouraged to do more private work because they're not going to get paid for it?
It's a very difficult challenge, and that's a difficult one to answer because nobody knows how things are going to go. But energy costs is one component of running a dental practice, which is very expensive.
Yeah, I was going to say, presumably they're pretty high for
yes. So our costs generally for a variety of things, whether it's materials, staff, equipment, servicing, maintenance, those are pretty high costs anyways. So again, I don't know an exact percentage, but I would say energy costs probably, I would say, between 5 and 8% of the cost of the running of the practice. So yes, it will have an impact. Personally, for my own practice, it's not something I'm sort of hugely panicking about, because obviously I recognise all my other costs. So I hope that this isn't going to have a huge impact, but every practice is different, and it may well have some impact on some practices.
Any further questions?
On 2.6, it was talking about staffing issues, retaining staff. Is there any data on that, just to show like month or year on year of the staff retention?
No, there isn't any actual data on that, I'm afraid. Obviously, it's just a lot of it's more anecdotal from practices, but obviously practices are suffering those types of issues. Health Education England is actually trying to do a workforce review to try and look at those types of issues and trying to understand that a little bit more. But people have decided through the pandemic either to reduce their work commitment for one reason or another, or they've actually looked at how they're being remunerated for that job, the health risks they might be putting themselves at in being in that type of employment compared to other types of employment they can get and get far higher wages for. So it's a very difficult scenario.
Next item, as I'm sure the first one, so and just dentists moving or terminating their contracts. If that does happen, obviously we give us that notice. The activity is being dispersed back within that area as well. I think there's a couple that have come back and have dispersed those. And if obviously they aren't successful in terms of expression of interest in terms of the full dispersal, they will go out slightly wider, just with that provision in around that area.
And just expand on that, just to reassure you a little bit. When a practice has a contract and moves over to being 100% say private, they don't want to lose all of their NHS patients. They're going to convert a percentage of those. On average, they convert about 60% of those patients. So that activity that we had, there's quite a bit to move to somewhere else, because obviously that will then generate more access for more people that couldn't get access before, because 60% of patients haven't moved from that original practice.
Any further questions? No. Okay, so the recommendations: to consider the report presentation, to make further comment, recommendation for discussions. on the report presentation received. I'm conscious that we haven't actually discussed fluoridation.
Yeah.
So I suppose, I would like to know a lot more about fluoridation and the impacts and benefits and that. And so I think it'd probably be prudent to ask the cabinet member to look into it and feed back to us in the new year when we see how progress is going.
Okay.
Yeah.
Is it worth trying to add a recommendation to see why people are leaving the dentistry as well? To see if there's a common theme.
Leaving dentistry in what respect, sorry?
I mean, not when dentistry are not retaining staff, to see if there's a common theme why people are leaving. See if we can address that problem.
I mean, that's a piece of work that Health Education in England are underway at the moment.
Yeah.
It is quite a vast piece of work, that one, so we might not be able to bring back any answers on that subject in 6 months' time.
At the present moment, it's commissioning those initiatives, it's trying to obviously incentivise, make it attractive to obviously get that uptake in line with the whole contract reform as well. And like Adam and Margaret said, it's not a quick fix overnight. We've got things in place there. I think it's just these things that it's just going to take time. But where patients aren't getting that access, we do encourage signposting to the NHS Customer Contact Centre as a complaint that we can really look into it, triangulate and actually ensure that practice can be adhered to.
Okay, thank you. So we're happy with the recommendations as we stand then?
Yeah.
So I still request that the cabinet member looks into fluoridation and issues as a report to CYP in the new year. And would you like, does the board want to hear again how progress has been made in the new year?
Chair, I think we should, yes, we're expecting the impact of those changes just to kick in by the end of October. Let's see whether that manifests itself in terms of the satisfaction really for our residents. Yeah.
In terms of the reporting of that, if the contract changes in October, with the submissions of forms and how the forms of the claims of treatment are actually made, it probably wouldn't actually see any data to actually give you a concrete sort of answer until sort of February or March time.
Oh yeah.
That sounds
That'd be ideal.
Yeah.
Paper probably is lengthy, obviously this was quite detailed paper, so obviously a bit more supplementary.
Yeah, that's
just to give you an update, that's
okay. Yeah, we're agreed on that. Yeah, I'm agreed. You're good. Right, thank you very much and thank you for coming. Thank you. Thank you. Right, so moving on now to the next item 6. Neural developmental pathways, children and young people. I'll pass you over now to Nicola.
Yes,
thank you.
I'll show the presentation on our
Yes.
Thanks everyone. So I'm returning to Scrutiny today to pick up some specific queries that were raised last time with regards to assessment pathways for neurodevelopment, which includes autism and ADHD. So the first thing I just wanted to bring to the board's attention is a piece of work that we did quite early on in terms of looking at the support that is available to children and their families, which, as you can see from here, we put the child at the centre and at the top, and then there's a number of layers to that support, which of course begins with the support from their family and their friends. And then there's some of the commissioned services and the information that's available throughout the system from the local authority. There's also the voluntary and community sector support that's available both locally and nationally. GPs, schools, early years are obviously key areas of support. And then through to NHS services and clinical assessment, which is there towards the bottom, and additional support that's available for mental health needs, such as the CAM service and clinical psychology. So in terms of the historical perspective, I was asked to share some information about that. So I think the key points from here, so the blue line is the demands that we would expect to see for assessments in the system based on national prevalence data, which is the line at the bottom. The capacity of services that we currently commission is the yellow line. As you can see, we have increased that, and it's way above what we would expect demand to be. The green line is then the actual number that we've managed to assess, and you can see that there was issues around the ability of the service to assess, which dropped off significantly during COVID when the waiting list in the south was closed under the guidance of NHS England. And that's then picked up again. So capacity and the number of children and young people that we assessed is now aligned. And then the orange line across the top is the demand. So you can see from there the spikes in September after the school summer holidays, particularly around 2021. You can see how it dropped and then it came up again. And that's a theme that we would expect to continue this year when we get that data following the schools going back. So you'd asked for specific figures around the waiting list. So just to be mindful, NHS services don't split between city and county. We work by GP surgery alignment. So it's north and south for us. So this data does include Southern Derbyshire GPs as well as Derby City. So the way the pathway works is in the south, the referrals come through what's known as the NDMDM, which is the Neurodevelopment Multidisciplinary Meeting. That is via the single point of access. You sometimes hear that called the SPOA. And from there, the multidisciplinary team will meet and decide what pathway of assessment is for that child. The majority of children go straight through to community paediatrics, and that, especially for younger children, is the only specialist service that's required to undertake the full assessment. For some children, it includes clinical psychology, which is offered by where the service is commissioned through University Hospitals Derby and Burton. It can sometimes also include CAMS, which is Derbyshire Healthcare Foundation Trust, and speech and language therapy, which is provided by Derbyshire Community Health Services. So you've got average numbers there. You've got the first three columns are the average numbers of children, and the final two columns are the average weeks. So this is the position as at July 2022, and I'll come on a little bit later to talk about the research work that we're commissioning to get a much better understanding of that. One of the questions I was asked was around the timing. How long does it take from when a child first has an appointment with a specialist through to them actually receiving the decision? I don't have that data. That is part of the information that our research is looking to gather for us. So in terms of our plans to tackle the waiting list and the average waiting times, we are planning to buy an additional 920 assessments per year for the next 3 years. The intention is that our capacity will be well beyond that which we would need routinely, but we have to do that in order to get the waiting list down. What we're also looking to do is to do that through a community-based model and to maximise the support of all organisations, not just the NHS, so to look at the voluntary sector, school support, local authority support, and those services that are already supporting children and their family to work together to create a model that's as efficient and as effective as it can be, to maximise our throughput essentially for assessments. We did a survey with families a while ago when we were looking to, when we published some online support to families, and 30% of the families that completed that survey said that if they had additional support, they wouldn't have sought an assessment. So part of the work that we're planning is through some clear coordination of the support that's available, some communications and some clear signposting to reduce the demand for assessments, which is way beyond that which we would expect it to be. And part of that is through the emotional health and wellbeing website that we have, where there's some additional help through YouTube style videos and some contacts for key organisations that can offer help and support. The other part of the work is to look at triage and to try and reduce our waiting list further through a community-based model with clinical oversight to offer support and help earlier, prior to an assessment rather than after it, where that's reasonable. And then the last thing I've touched on all the way through really is the importance of the communication, and to do a programme of communication across schools, GPs, early years, support, to make sure that they are informed of the help and the support that's available, and signposting. So you did ask me to say how much money is being spent on neurodevelopment assessments. We can't specifically say, partly because we don't have sight of all of the funding. If it's through the voluntary sector and it's through local authority, we won't see that in the NHS. And partly it's because we align our services based on the skills and the expertise and meeting the needs. So the example I've given there is the community doctors, the paediatricians. Their skills and expertise isn't just in providing assessments. They also assess for general medical problems, complex disabilities, sensory impairments, which visual difficulties or hearing loss. So we don't have a dedicated neurodevelopment assessment team because the specialists that are required to contribute towards the assessments cut across all the other specialisms that those professionals have. But what I can tell you is in the last 12 months, we have invested £477,000 in neurodevelopment assessments, and that has brought an increase in capacity under the existing teams through evening and weekend working and maximising the staff that's available. And also we purchased some online assessment capacity from a partner organisation as part of that as well, where that was clinically appropriate. Not all children can be assessed remotely, so that's part of that. I can also tell you what we hope to spend over the next 3 years. Just to note, NHS England or the government have not given us any ongoing funding specifically to address the assessment waiting list. It's a national issue, which a lot of systems are grappling with. But what we have got commitment for locally is for that £5.3 million to increase capacity further, to develop our community support that's linked to existing organisations and services, to increase early support, and that funding is across the whole of Derby City and Derbyshire, so it's not just the city. You may have picked up on some communications from the government around the Department of Health releasing funding for CYP waiting list. By the time that we were given our share of that funding, it was £120,000 for us in Derby, Derbyshire. Clearly, it was nowhere near the level that we needed to really grapple with the waiting list. But what we have decided to use that money on is to fund the research, which I'm going to talk to you a little bit more about. So the intention of the research really is to make sure that we fully understand our position and to check that the next steps that we've planned locally are the right ones, and we will use the research to inform that and to guide us. So we've commissioned an organisation called Themis to do some independent primary and secondary research for us. The aims of that research is firstly to understand the prevalence, demand and equality of access to services, both in terms of the geography where all this demand is coming from, which is way beyond that which we'd expect, and also in terms of aligning that to more of the public health indicators as well in terms of inequalities, areas of deprivation, and to see how that aligns. We've also commissioned them to develop a shared understanding of the model that we currently have in Derby and Derbyshire, and to make some recommendations to support scenarios from the pathways. As part of that, they will engage some stakeholders to understand that from the different perspectives, and that will include children, it will include families, schools, GPs, social care colleagues and others. And then also to explore the barriers, the opportunities and the requirements for our future pathways, very much being driven by children, young people and their families. So this slide just summarises the approach that they will take in order to do that. I wasn't going to particularly talk that through, if it's self-explanatory. And we've talked a bit about this being across the city and also across the county, just to highlight what that means for us. So it goes way up to the High Peak area. With the change around the NHS and the creation of the integrated care system, we now have Glossop as part of our ICS, which is the little corner on the top of High Peak, which is now being introduced as well. So the output of that research will be a summary and comparison of local regional data, some co-produced proposals around pathways, reflections of experience, identification of children and young people and their families' requirements, and to co-design some recommendations to take us forward. So subject to that learning from the research and the specific plans that are coming out of that, our current thinking is that we need to strengthen how the system works together to support children and families. We've been working with families on the creation of community hubs to coordinate support and give children and their families one place they can go to for that. We are hoping to empower schools to support and give them the information that they need to support children and families. And similarly with health visitors, GPs and other professionals and support services across the system to do that. We need to continue to maximise our assessment capacity, and we need to continue to strengthen those links with the community. And I've said there, we're seeking to blur the boundaries between the NHS assessment and help and support that's available across the whole system. So one of the other things I was asked to do was specifically to talk about the help and support that's available to families whilst they're on the waiting list. The emotional health and wellbeing website, I've already talked about, the link was on the previous slide. The Derby City Send Local offer contains lots and lots of information about organisations and services that are available. And some of that includes the support to schools via Send Support, Send ES service, Citizen Advice with Mercy Information Advice Service, all some services. There's a list there, I won't read them off. But that all of those are available with or without a diagnosis, pre and post assessment to support families. And as I said, that's all on the Derby City local offer. So I've just added a little bit at the end. There's quite a lot going on. There's a lot to take in, and there was just some key points that I wanted to highlight to the board. We can't take the neurodevelopment away. There isn't a cure. There isn't a treatment. But what we can do is make sure that we help families to find ways to support each child and to give support to them to do that. This isn't a health issue. We're going to have to work together in order to move this forward and put some solutions through the system. I think we just need to be mindful that schools, early years, GPs and early help are the most frequent place where that first contact is, and that's the part that we really need to focus on in order to support the skills, experience and capacity to support that they already have. And then finally, the emerging information that we are getting is that peer support is just as important as professional support to these families. Thank you. That's it. I'm happy to take questions.
Thank you, Nicola. Can I just ask, who refers for assessment? Do you accept self-referrals? Is it referrals from professionals?
It's not self-referrals, so schools can refer, professionals within the system can refer. We don't, the reason that parents can't self-refer is that it's really important to support the graduated response, that the earliest opportunity for schools, for GPs and for other organisations to offer support has been tried before it comes through to the specialist service that in order to carry out an assessment.
Yeah, thank you. So that really concerns me that the service is trying to cut like 100 assessments a month from a need-led service that's been, children and young people are being referred from professionals.
That is aligned to the rate of children that are taken, that where referrals aren't appropriate. That's the word I'm trying to.
Yeah, if diagnosis is missed in a child's life and that impacts on their life chances of a child or a young person, what would the legal position and any legal implications of that be?
I don't know to hand, but I can certainly find out for you.
Thank you. I'll pass on any questions.
Good.
That's what it is.
Yeah. Just to clarify the funding, because I like the 920 extra assessments, obviously that's fantastic. Is that being paid for by the 5.352 million, or part of it, but from that part?
So the first point, the 400 has already been spent. That's done. So going forward, we've got 5.2 million across the next.
Yeah, is that partly paying for the 920 extra appointments, extra assessments?
sorry, then the five,
You've got 3 years of 920 assessments extra over 3 years. I was just wondering where the funding for that's coming from. Because I'm not quite sure about funding for health, because I know there's obviously all sorts of pots, and that. I was wondering whether it's public health, NHS, councils, who's paying for that?
it's coming from NHS England, ultimately, yeah. So the ICB, the Integrated Care Board, are given an allocation of funding from NHS England, and they are, some of that they're told what they have to do, and some of that they can choose. And the Integrated Care Board has chosen to spend that money to tackle it.
Right, okay. Excellent. Thank you.
Okay. Right, you back?
I've got one point, one comment and 2 questions to ask. There's a real benefit to supporting young people and children with neurodevelopment earlier. First question is, do families always need medical assessments to claim disability benefits for children? And second question is, would assessments from the voluntary and community sector or schools be accepted as evidence of neurodevelopment?
I can't answer the question around disability benefits. I need to ask the local authority colleague, but I can certainly come back to. Can you repeat the second question? Sorry.
Would assessments from the voluntary and community sector or schools be accepted as evidence of neurodevelopment?
We're governed by an organisation called NICE. That requires a certain level of clinical expertise and professional qualification and obviously experience and quality assurance in order to undertake assessments. If a voluntary sector organisation can fulfil the requirements of NICE and are quality assured by the NHS in order to deliver that, then there is no reason why the people who work within that area can do it. I think that the challenge is really the amount of control around who's and the qualification in order to undertake it. So as things currently stand locally, that isn't the case, that they will not be able to do it. Don't know whether other areas commission other organisations to carry out that are outside the NHS as an organisation, but obviously are within the requirements of what the NHS needs for them to do it. Sorry, that's a bit of a roundabout answer. I'm thinking and talking at the same time. Does that answer?
Yeah.
Yeah.
Thank you. Councillor Bonster?
Yeah, just in terms of tackling the backlog, I can see you put your plans in place for that. Just looking at the second and third columns where we're talking about the average numbers referred and the numbers assessed, it just looks like we're never going to sort of catch up. Even if we do catch up, put interventions in now, the capacity that we currently have isn't sufficient to meet the demand. Are you looking at increasing capacity on a permanent basis, or do you think that these measures to reduce your 30% will tackle that?
Yeah, so we've modelled through the impacts that we're expecting of all the different work, and we predict that over the 3 years we should be able to get that waiting list and waiting times down to acceptable levels.
Yes, but even if you do that, your capacity is still not meeting, your month by month demands. That's what I'm concerned about, that we're going to be in this situation again. But I mean, in terms of community paediatricians, for example, I think are there only 2 or locally, is that enough? Do you need to engage with more of those specialist services on a permanent basis to keep a lid on this.
So to tackle the waiting list, it's not just about commissioning more. It's about reducing that demand and bringing it down. So that's what we've modelled as part of that, and through modelling it, that's how we predict currently that we'll be able to bring it down. With regards to professionals in the system and who's undertaking the assessment, we are looking to try and change our model to reflect the assessment model that's been adopted in other areas of the country who have managed to tackle it. And this is part of what the research is hopefully going to do for us, to give us some options around how we can do that.
I think that's what worries me, that we're not actually tackling the demand. We're managing the demand by making the start figure smaller. And then that worries me, that families could be missed, or not assessed, and that what we're actually doing is trying to reduce the we're reducing the numbers rather than dealing with the demand.
But the plan is to do both of those things. Obviously, we're running it alongside each other.
Any further questions? So are you happy that you have enough funding in the system to be able to meet demand moving forward for the next 3 years?
No. We are satisfied that we have a plan that will tackle it within the constraints of what's available to us as quickly as possible. If we had £10 million available now, we would tackle it now. What we would like is for it to be nationally recognised, that this is a national issue, and some funding to be made available nationally to support it. As I said before, the funding that was announced nationally, it doesn't scratch the surface. And that's the challenge that we've got as a system. So we are having to prioritising this above other potential areas we could spend that funding. The plans that we've got, we are confident that we can tackle it, but it's not going to be as quick as we would like it to be. Does that make sense?
Yeah. Okay, thank you. So moving on now to the recommendations. To consider the presentation and make further comment, recommendations, discussions, presentations received. I'd like to put forward the following recommendation. Following discussion that we've just had here today, I think as a board we should be writing to the Secretary of State for explaining what the situation is here in Derby, and urging them to properly fund their developmental assessment services.
Your support would be appreciated. Thank you.
Yeah.
Can I argue with that?
Yeah. So yeah, we're all for that. Yeah. Right. So yeah, that's passed. Thank you. No. Any further recommendations? No. Okay, right. So thank you very much. Thank you for that.
Thank you.
So moving on to item 8 now, opportunity for all strong schools and great teachers in child education, white paper and so green paper from Pauline Anderson. I'll pass you over. Thank you. Hi.
I'm just going to log on, because I did a very noisy attempt earlier, and I now have to do it. I haven't done that before, I've got to say. I'm just going to get into the teaching.
Oh, I've missed one out. Yeah, I've missed one out. We've missed item 7, so we'll go back now to item 7. I think you're also. Right, so the item 7, sorry, I missed item 7. So update outcome of this end inspection. I think that's also yourself anyway, isn't it, Pauline?
Yeah.
Yeah, thank you. Sorry
Someone's
about
muting me, which is very nice. So it's the, sorry, I've got two, so I'm just looking at the send. Yeah, because I haven't got both of them first. I'm not sure why. Maybe we can live with that, but what is it not? Favourite pictures seem to look up a bit more. So there is a little bit of echo on this, but I'll sort of live with it. I've got a real glasses problem because I need it to look at my screen. I can't really see what's there anymore. I've got this. I need to go to varifocal obviously very soon. So I understand that this is really a kind of question about post inspection and how are we doing, and it was mainly focused around collection of parental views. And kind of progress, sort of progress generally, and I've tried to focus it in, but of course happy to pick up kind of wider implications as well, because SEND, very similarly to your NDP work, is very broad. So just to give people who perhaps aren't as familiar with the chronology, was a failed full inspection of the local area, which includes all partners in the local area of SEND. Within the council, there was a change in personnel, and that's when I became involved. And for the first time in my life, I became director of inclusion. And I've got to say, it's one of the best things I've ever done. So interesting, challenging, and it really is. It's a very great privilege to have it. We were given at that point during the written statement a five-point action plan, and that was approved in December 2019. So actually, these processes are quite slow. If you look at the full inspection being June, and then the final statement, which is our action plan, being approved in December. And then what happens then is there is a revisit from Ofsted and the CQC, which happened by then about just over 2 years later in November 2021. So it's not, if you fail the full inspection, the revisit focuses on just those failed areas, those 5 areas. Then next time, assuming you come out of those 5 areas of weakness, you will be inspected in a normal cycle. So, it's just to explain how that works. And the 5 areas of weakness were, just to remind everybody, joint commissioning with health. Lots of us were involved in that. Very close together, haven't we? The lack of a SEND strategy, again, that's for everyone across the local area, but that was led by the LA Grinding. EHCP, timeliness and quality, that's a statutory function of the local authority, so we led in that area. But again, there are implications for everybody there, schools, health, etc., social care. And of course, Nikki's favourite, the neurodevelopmental pathway and waiting times, and a lot of the work that you've heard this evening is a product of the work that went into this post inspection, and then partnership with parents and stakeholders, which our major wanted this evening. So we had the action plan approved 12 weeks before lockdown, which meant that from there everything went online, and I think that's really important. I was just getting into it, being able to get out there and meet with parents, young people. We had quite a big event down at Pride Park, and I was just looking forward to having those kind of things on an ongoing basis, and the kind of work that we've done with you, Adele, engaging with young people, and we just couldn't. And it was just really, really sad. We know why we are where we are. Then we had a revisit from Ofsted CQC in November 2021, and all areas were judged to have made sufficient progress, and the written statement of action was removed. So we're now in that normal inspection cycle. But we do have work to do, and we absolutely knew even going into that revisit that we have areas to continue to develop, and we are constantly, very similarly to the NDP pathway,
The demand for EHCPs continues to rise. Extra staff have been appointed, and I've really appreciated the support from colleagues in getting those extra staff in place. And currently more are being recruited because that demand, I can see our colleagues from schools who are involved in schools, can see that demand for EHCPs is just going up and up. So we are, whereas we improve timeliness and quality, actually then the demand means that we're spread more thinly, so people have caseloads of hundreds and hundreds. We were trying to reduce those caseloads to 250, and they've gone back up to about 400 per EHCP officer. So you can see why there's a challenge. The NDP work you've heard about continues, and working with parents, young people and stakeholders, and it has intensified now post-lockdown, so lots of work is going on. Just to be a bit more formal, just to kind of reassure you, we are listening. In lots of ways we're listening, and one of the things that we do is to survey parents. So we're continuously surveying parents on their experience of the EHCP process. It was extremely painful to do this in the beginning because virtually no one said anything good. It was very much a broken system, and I'm still absolutely not happy about where we are, but we have seen improvements over time. So now we see 66% of respondents are either positive or neutral, and in SEND, neutral is probably better than in lots of areas because it's such an emotive area, and I feel emotional about it as well. But we do know that there are 34% people not happy, and we know why they're not happy. So we've picked out their comments, and we can go into absolute detail. And sometimes they feel, the EHCP just wasn't capturing their child. Sometimes they felt, yes, the end product was good, but the process was bad. Sometimes they're not happy with the end product. Sometimes they're not happy with the recommended placement. They don't want their child to go to that school. So it's a whole mixture. But the only way that we can improve as a service is to work together and actually, talk to parents, continue to ask questions and respond. And it's a continuous improvement cycle. And we just want to see it better and better. Again, we are listening. We have consulted on the SEND Capital Programme, which is the building work to be done to expand SEND places. We were very broad in our view, which we had a pre-consultation period and a massive call for views, and that call for views informed our SEND consultation. So, we kind of did a double listening on SEND consultation. And we found that having more places is one of the greatest concerns. We know that. The SEND Capital programme, understanding it is really, really important to people. Create more Derby school places for SEND, because there's SEND places and there's Derby places. That's a biggie. We need to expand places in existing schools and look at where the space is around some of our existing schools, because they're already well liked and respected by parents. And we have also applied for a free school based at Alice Street Hall, which is just at the submission interest stage. So over 75% of respondents agreed or strongly agreed that the proposals were right. And we had some really useful comments, again, about